Hello, Facebook Live folks who are watching. I'm Dr. Bill Bird. Thanks for joining us today. I have with us Xavier Marino. Hi, Xavier.
Hello, Dr. Bird. Pleasure to be with you, sir.
Yeah, good to have you. So, Xavier he's all kinds of things, but for our purposes today, Xavier is the manager of our pain clinic here at the hospital, and he's also a CRNA in our operating room area. So he wears a couple hats at CGH. And and by the way, those of you who are listening, feel free to, as we're talking, send us questions. We'd love to see what you're thinking and what you're curious about, and we'll try our best to answer those questions. As always, what I've been kind of doing is we'll do some stuff with Xavier, talk with him about what he has going on. And then when we get done with that, I'll go into some of our COVID stuff and what's going on with COVID here at the hospital and as best I can in the area. But back to Xavier, can you, for the folks who are listening, in a nutshell, tell us what a CRNA is, what they do, how they get there?
Great question, Dr. Bird. A CRNA is a certified registered nurse anesthetist. Every CRNA goes to nursing school first. After nursing school, whether it's a bachelor's degree, they end up going to an intensive care unit, approximately 3 to 5 years of critical care experience. Most of the schools actually require those nurses actually get national critical care certifications first. Then after that, they get a certain amount of level of experience to actually apply to a doctoral program. It's a doctoral program most around the country. It's about 3 year long. The first year and a half is all didactic education pieces, gross anatomy, pharmacology, chemistry, physics, and that kind of thing. And then from there, it's all clinical time. It's hands-on, learning how to place people on ventilators, place endotracheal tubes, do invasive procedures like nerve blocks, placing endotracheal tubes, like I said, central lines, those kinds of things, providing patients care under anesthesia.
Yeah. Okay. Good. So, long story short, you got a lot of training, and you help out in the OR when people need anesthesia, when they need to be put under or sedated or whatever needs to happen for them to have a successful surgery. You're part of that team that does that.
Yes, sir. We also provide pain management as well in certain instances. For example, we do nerve blocks to provide some pain relief, in particular for those surgical outcomes, as well as we provide obstetric analgesia, for example, labor epidurals and those kinds of things. Or having cesarean section, we're there as well.
Yeah, so I think the vast majority of our population, unless you're other than those who are having surgery done, they might see someone like you if they're having a baby and they want an epidural.
Yes.
Or they're having a baby and they need to have a C-section.
Exactly.
Yeah.
Luckily, sometimes we can actually use that epidural that we've already placed as the anesthetic versus the spinal anesthetic as well.
So, yeah, good point. Okay, so now folks have a sense of what your education is and background. But what I want to segue into right now is the pain center, pain clinic at the hospital. So, and this is Dr. Ibarra has a team of staff. I think there's how many folks are on that team, Xavier?
We have eight members right now, Dr. Bird.
Okay, all right. So yeah, they do a really nice job. And let's just start with, when we talk about a pain clinic, what kind of conditions is that pain clinic treating right now, Xavier?
Normally, usually it's an osteoporotic kind of scenario. Patients with severe osteoarthritis are ended up coming in for types of injections and also some medication management. Very little medical management. A lot of it's interventional procedures, as well as referrals also to physical therapy to help with those kinds of issues. The staff there are wonderful. If you ever need to come to see them, I am the luckiest manager director here at CGH. I have the greatest staff there. I'm the lucky one to work for them. We have a great reception staff by the name of Kim, who is kind of a jack of all trades for us. We have some phenomenal nurses, Teresa, Sandy, Jamie, Betsy. They do a wonderful job. Another young lady by the name of Julie comes and helps us as well. We have some phenomenal radiation techs that come and make sure that we got the right stuff going on, right pictures. And then Dr. Abar is a phenomenal interventionist. He takes the time to listen, takes the time to read the pathology, read your x-rays, read your CAT scans, your MRIs, and comes up with an evidence-based approach to how he's going to treat you. And it's not just all about intervention. Sometimes it's about letting the body heal itself. It's an old metaphor in pain. So he takes that into account. So if anything, I'm here to brag about them.
Yeah. Well, yeah, you guys you're kind of like the silent department. We don't ever hear about you. So you're like an umpire. If you're doing your job right, we don't hear much about things, and you got to do your job right and get things done for patients.
Well,
So my experience with the pain clinic is a lot of what you're taking care of are folks who have pinched nerves in their lower backs and pinched nerves in their necks.
exactly.
Yeah. Okay. And you may do some med management, but just for folks who are out there and are listening, more the purpose of the pain clinic that we have at CGH is for identifying those pinched nerves, if you will, and dealing with those with some type of therapeutic injection, rather than treating someone with ongoing pain medicine of some type or another.
Exactly, Dr. Berg. Our role is to kind of fit in that area where your primary care physician has already tried to assist you with your pain management issues, and they typically consult us to kind of see where we can do to try to help you out. For example, if you have a type of nerve injury that's running along a dermatome, and we know it's a pinched nerve that's causing the issue, Dr. Barr can skillfully go in there, take a quick x-ray, take a look at something called fluoroscopy, where we take a look. We place a small, very close needle close to that area. They actually inject some local anesthetic, sometimes some steroid in there, helps to decrease the inflammation and let the body kind of help itself. And like I said, they do a phenomenal job.
Yeah, they do. So, yeah, just to kind of summarize that. So, if someone comes in there and they need an injection in their lower back, let's say for a nerve that's pinched, that's causing some problems. Can you kind of walk us through what the steps would be for that person again? How that procedure goes down? I know it would probably, in hindsight, I would have had Matt and his team put something up on the screen to kind of like a visual, but we don't. You can give us an audio on what the visual should be.
Right. To be honest with you, most of the procedure that we do, like I said, are either cervical, thoracic, or lumbar, the lower back. And what we do is we typically will take them into the fluoroscopy room, the procedure room. We have those patients actually get up on a table and actually lay on their stomach for the most part, is the approach that we typically take. We clean off the area, make sure it's nice and sterile. Everybody there is making sure that everything's nice and clean and prepared and ready to go. Once the patient's into place, we actually give them a little bit of local to the area so that we can actually insert a very small needle to the area where the pathology is. And that's the key about pain management is we're looking at something that's the tip of the spear. We're not looking for a broad brush. We want to make sure that we're actually providing direct treatment for the pathology, what's going on. And if we could do that and actually get the best outcomes with the least amount of medications and those kinds of things, that's the better approach. That procedure itself, for example, let's say it's a lumbar epidural steroid injection that takes typically less than 5 minutes from the time that you're in the room and they're getting going. And then after that, you're back up and already walking out towards the recovery room area. So it's a very quick procedure.
Yeah, that fluoroscopy, Xavier. So that is, just so folks understand that's like real-time x-ray. While the needle's going in, they can see where the needle's going.
Yes, it's pinpoint. It is pinpoint accuracy. So you know exactly where you're going at all times. So that, number one, that obviously it's kind of neat to have, but number two, the biggest point is it's a huge safety issue. Mm-hmm. So we know exactly where you're at all times. Before, when they used to do these 25, 30 years ago, we actually didn't even use fluoroscopy when we did them. We actually just tried to elicit a nerve response. That's how they used to do it. But now it's under fluoroscopy. We also use ultrasound guidance for some types of procedures. And it gives you a pinpoint accuracy of exactly what you want to do. So it decreases the safety concerns very much so. So it's a much safer process.
Yeah. I want to make sure folks hear that because that is a big piece of this. So good.
Absolutely.
So like if I wanted, if all of a sudden I started having pain in my neck, Xavier, can I call the pain center and get in myself, or what's the process for getting in there?
That's a great question, Dr. Berg. Most of the time that people actually have neck or low back pain, it actually goes away on its own within, 2 to 6 weeks. So
Hmm.
my advice would always be to kind of do over-the-counter medication, see your primary care physician, and see if they can't help you with that kind of scenario. Sometimes they can notice that it's kind of made more muscular pull than anything else, and they might actually refer you to maybe a chiropractor or to physical therapy. But if this is something that's been going on for a while, you're also having something that we call red flags, where you're
Yeah, what are
having,
the legs?
right, you're having this burning sensation all the way down your arm or down to your buttock or down to your foot or those kinds of things. We call that radiculopathy pain that goes along the nerve fibers and those kinds of things. That's something that we're going to want to have to take a look at. So typically primary care physicians might see that, doing a quick exam, and probably recommend some type of imaging, whether it's x-rays or a CAT scan or an MRI, depending on your health history. And that information is actually sent to us. And Dr. Barr screens those to make sure that that's something that he can help you with. And once he's made that decision, we actually get you back onto the schedule, and you'll come in and do a consult with him. Once he takes a look at it, looks at you, does an exam, comes up with the best available option for you, then we'll walk down that steps as long as you're okay with that. We can send you that procedure. We'll set you up for another time for the procedure. Typically, that's within a week or two that you can come on back and get that procedure done.
Okay, yeah. So the flow is, first of all, give it a little bit of time unless you have
Yes.
these red flags.
Yes.
One of the red flags that I've just noticed for patients too is it's not just the pain down an arm or a leg, but if you have all of a sudden that arm or leg also has weakness in it,
Absolutely.
classically we'll have someone like that has a foot drop. That is a red flag that you need to be seen right away for. Uh,
Yes.
that is a do not pass go kind of
Yes.
situation. you,
Absolutely.
you go
Another
right.
one too is sometimes people don't realize it, but they also have muscle atrophy in certain areas. They also have sensory issues. For example, they don't feel it as cold or it's a little bit number than another area. Those are red flags to me as well. Those are things that you need to get evaluated. If you haven't had a CAT scan or an MRI going through your primary care, that's something that you have to get
Yeah.
addressed.
And atrophy, in other words, that's if your muscle shrinks. So if your muscle
Absolutely.
like it looks smaller, all of a sudden you go, geez, that muscle's smaller than the other side or than it used to be. Another red flag.
Yes.
You mentioned imaging, Xavier. Because this is so pinpoint with what we're doing, is it fair to say that everyone that sees Dr. Ibarra is probably going to have an MRI or a CT scan done before they see him?
I wouldn't say everyone. I would say probably a high number. I wouldn't
Okay.
say everyone, just because of, like I said, sometimes that pathology doesn't kind of shake itself out. You're not really sure what's going on. They so maybe your primary care is not really sure what's the best route to take, and yet they consulted us. And it's there are times that we end up saying, okay, well let's do these types of imagings first before we move any further, so we can see what we can do to help them.
Okay. Okay. And you already alluded to this, Xavier, but I just wanted to hear again. So how does Dr. Ibarra and his team partner with our physical therapy rehab department in terms of deciding how to take care of a patient who has, let's say, low back pain?
If specifically, let's say that somebody has low back pain and let's say they have imaging, their imaging doesn't really show anything that's showing anything that is something that we could do with an intervention, for example, an injection or something. Dr. Barr does believe in physical therapy, chiropractor, those types of things, those other types of medical modalities to help with that. For example, physical therapy can help with stretching exercises, strengthening exercises. One of the bigger things with low back, for example, is just poor posture. People don't sit up correctly. They kind of bend down to grab things inappropriately. Uh, they don't shift their weight appropriately. They don't get a good balance. So those types of things that they can do to assist with those. There's other kind of modalities as well, but those are just a basic way of looking at it from a physical therapy standpoint.
Sure. I'm guessing that most of our listeners have heard of them. They have had it, or a friend or family has had a nerve ablation procedure.
Mm-hmm. Yeah.
So can you kind of talk through what that is and how that compares to your injections that we do with steroids for
Okay.
folks?
Well, when we start doing radio frequency, it's called radio frequency ablation. And what that is actually before we ever get to that point, the patients typically have something called a diagnostic or a prognostic block. What that means, we do a small little injection of local anesthetic to an area of nerves that provides sensation and coverage to that's causing you the pain. For example, let's say it's in your hip or in your lower back or those kinds of things. We do a diagnostic block or prognostic block with that injection of local. If a person gets 50% or more pain coverage from that, it tells us that a radio frequency ablation will probably work well for that. There's a better outcome for that. So what we do is after they've had that diagnostic block, they come back for the radio frequency ablation. It's the same process where you actually place a very small needle next to the nerves that actually provides sensation and motor, those kinds of things. We actually hook it up to a small little device that actually heats up the nerve area. And what that it does is actually impedes the nerve pulses that actually come from that location all the way up to the brain. In pain, there is an old saying that says pain is not pain unless it's in the brain. Well,
Hmm.
when we do radio frequency ablation, whenever we do steroids injections, those kinds of things, it actually blocks the transmission of that local area all the way up to the brain to provide sensation, communication to the rest of your body, tell you that you're in pain. But if we're able to block that transmission, it decreases the amount of pain that person has. So that's
Oh,
how it works.
all right. So you're blocking the brain from feeling the pain.
Essentially.
That kind of rhymed too.
Can
All right. So
we start a song?
yeah, let's go with it. Let's go with it. A little rap action. I'm all over that. So Xavier, how long do those ablations last for? Are they permanent, or do you have to kind of touch them up, if you will, at some point in time?
Typically, for most people, it's about 6 months to a year. It can last a little bit longer for some. It can last a little bit less than others, but for the most part, 6 months to a year. An RF will actually provide pain relief.
Okay. So it's a little different from too, in that, like, you're not trying to reduce inflammation. You're just trying to get rid of the pain. So
Right.
you're saying, okay, you got this. It's going to be there. We're
Yeah.
just going to basically try to blunt this pain for a period of time.
And Dr. Berg, can I add one other thing
All
about
right.
that? One thing about pain management, people think it's all about just pain, taking away your pain.
Mm-hmm.
And I think probably one of the more important issues that people don't discuss enough is how about your function? So we'll talk about there's a VAS score. It's called a visual analog score, or some type of a NRS, a numerical rating score. What's your pain? 0 out of 10, 0 out of 7, whatever the case may be, whatever type of rating scale you want. But the one things that a lot of people don't do is think about functional activity. For
Mm.
example, I've had a patient that I've taken care of in the past where they came in to have an injection. They got an injection. They came back 2 to 3 weeks later and said, "Oh, I didn't get much relief from that injection." I was like, "Okay, well, the last time I saw you, you came in a wheelchair. How did you get in today?" "Oh, I walked in."
Oh,
That's a big difference in functional activity.
yeah.
However, they would still have perceived pain in other locations because we have in our body we have something called perceptual dominance, where we can have pain in other locations too that flare up once we've actually the one area already taken care of.
Yeah.
So the big issue that comes along with pain management is functional ability too. So
Mm.
just wanted to throw that out there just so that people are aware that there is a difference between just straight
Yeah.
pain management for pain
That's
purposes
great.
versus functional activity.
Great point. So your goal isn't always to have them walk away from the experience without any pain,
Exactly.
to walk away with a better ability to function in life.
Exactly.
Yeah, good. Okay, we've talked about this radio frequency ablation and, of course, the injections, the steroid injections. Are there any other treatments that the pain center does that our viewers would want to be aware of?
Dr. Bear typically handles mostly a lot of cervical issues that require, for example, facet injections, which are some local anesthetic, possible steroid near the ears that causes arthritic pain in particular. There's also lumbar and thoracic and those kinds of things. That helps with those kind of disorders all the way up and down the spine for the most. That's typically what he treats.
Okay. Okay. Good. Hey, I want to change. Anything else about the pain center that I didn't mention, Xavier, that you think folks need to be aware of before I change gears and go to something else?
No, I just want to say that we're in this area of COVID that we have a limited amount of supply of steps that we can actually go through to get patients in and see and everything else. However, I have to, once again, I have to brag about the staff over there. When COVID hit, they were all on board about doing something called telehealth, which is something completely different from any one of us have ever
Yeah.
done before. But to give credit to them once again, they stepped up. We were able to actually see some patients via telehealth for follow-up visits to limit patients actually having to come into the hospital. Those are very limited spaces, but we can do that specifically for follow-ups, so that you've had a procedure done, you're doing well, and you just need to do a quick follow-up to kind of see how things are going and what any other recommendations. We could do that via telehealth. So once again, I just wanted to pat their back because they've gone above and beyond to try to provide services to the community. And that was a big change for them. And they
Yeah.
did it without a complaint. And I'm just very proud of them. So,
Yep. They did a great job with that.
yeah.
I agree. Good. Okay, so I'm going to switch gears, and we're going to go down to your home. We're going to go down to the OR
Okay.
and talk a little bit about some things that are happening in anesthesia in the last, at least at CGH, in the last 2 years or so, that I think are pretty cool and very helpful for patients. So we've been doing you talked about it earlier in our conversation, Xavier, that we're doing more blocks
Absolutely.
on patients having surgery. I'm going to have a kind of a 3-part question. I'll let you.
Okay.
I'll tee you up and let you start talking. Okay, but can you tell us why more of these blocks are being done?
Okay.
Why we're able to do them? Why we're able to do them here at CGH? And what's the benefit of doing these blocks for our patients?
Okay. This is going to be a long answer.
Go for it.
But I'm going to make it short, but I'm also going to make it personal. Okay.
Yep.
Quite a few years ago, I decided to join anesthesia, and my mother went through a horrible car accident. Okay. And she basically had broken bones from top down to the bottom. And long story short, my mother got to the point where she required a lot of opioids and has been basically hooked on those for a long time before she actually got weaned off eventually. I take that personal, that we're not doing stuff in the medical community enough to help patients and actually going that extra little mile. The problem is it's not an extra mile. Here at CGH, we have the utility to do this. We have something called ultrasound that takes literally no time. What I do is, for example, if a person has a lower extremity injury, I can take a look at the nerves that provide motor and sensation for that area. I take a small needle and I inject local anesthetic around that area. Sometimes we actually do put steroids in there. Sometimes we put some other ideas or other medications that actually last longer. So basically, I can make your leg numb for 24 hours to 3 days, and you're not having to take any opioids whatsoever.
Oh, wow.
One thing about healthcare that we've all have seen in the last 20 years in particular is this opioid epidemic. What are we going to do to actually help fight this epidemic? And part of that is using regional anesthesia. Once again, I go back to that old adage, pain's not pain unless it's in the brain. Well, if I can block that transmission peripherally at your leg and it not actually get up to your brain, you're not going to have a lot of pain.
Right.
And it actually helps with swelling too, in particular.
Sure.
This pro-inflammatory phase of when an injury occurs actually gets blunted by the local anesthetic as well. So there's ways that we can actually help with pain in the acute phase with surgery, so that you don't need to take a ton of opioids. Opioids they work. However, how they work is completely different from local anesthetics.
Yeah.
Opioids work in the brain. They make you not care about pain. They don't actually take care of it.
Yeah.
When you do local anesthetics, you do those types of medications at the site of where the injury is. It actually blocks the transmission. So you actually don't need to get systemic effects of opioids. For example, respiratory depression, you have difficulty breathing, you get really somnolent, you get so sleepy, you get nauseated, your bowels fall asleep, and those kinds of things. And all those have repercussions. And obviously, the longer you take the opioids, the longer the issues continue.
Right, and I just interrupt for a second, but and we know that with opioid usage, it's a numbers game.
Yeah.
That the certain percentage of people who go on opioids will become dependent upon them. It's pretty much, you can just research it and you'll see that. So the fewer people that are on fewer amounts of opioids, absolutely, good deal. So
and then that utility is actually all over the place, Dr. Bird, in the hospital. And I'm all about, I want to pat people on the back and just be proud of people because I have teammates in my anesthesia team that, like myself, would get up out of bed in the middle of the night for a person that's injured to make sure that they get the nerve blocks that they want or that they need, so that we're not loading them up full of narcotics. So a perfect example is, I'll just use my example. I had an roughly 80 something year old female that came into the ER in the middle of the night with a broken hip. Instead of her getting tons of opioids and causing confusion and causing
Yep.
all the other issues, I just went down to the ER, gave her a nerve block to her hip, and she was able to sleep comfortably until it was time for her surgery. She didn't need one opioid at all. So
Mm.
those options are there. It's just people need to want to do it. And I have to say, here at CGH in particular, our anesthesia team is all on board. We're essentially doing something called an acute pain service. Whether it's right away or within a few hours of them, that service is there. So I'm very proud to say that I work with a group of people that will do that.
Yeah, it's great. So, like, give me I'm trying to think of surgeries where you're doing blocks. Shoulders.
Shoulders are big.
Um,
Shoulders, elbows, wrists, knees, ankles, hips. Um, there's also diagnostic blocks or other types of blocks for traumatic issues. You could do blocks for rib fractures. We could do blocks for C-sections if patients have issues with spinal anesthesia. There's other types.
are you doing
Let's
any?
say somebody has a huge abdominal surgery. We can
Yeah.
blunt that as well.
Okay. Yeah. So that is that's a big deal just for those of you who are listening of how in the last how long would you say that period of time is when we've transitioned from not doing this kind of stuff to doing this, Xavier?
I would say the trend has, within the last 10 years of anesthesia, has been pushing towards regional anesthesia, which is something that was really important to me because, like I said, my mother having
Mm.
issues, they could have done a lot of other things that I learned in my training in particular that could have helped blunt that issue. Now she's a chronic pain patient with multiple issues, but they could have muted that pain if they'd actually done some of this technology, and it's been there for a while. I think the issue is that the training hasn't caught up. However, like I said, we're lucky that we actually have people here that are able to do that.
Yeah,
So it does help our community quite a bit.
I agree 100%, Xavier. I mean, my guess is, and you probably have a better handle on this than me, that for a community hospital to have the ability to do this and to have a team that's able to do this is, I don't know if unique's the word, but I'm wondering if it is. What would you say about that?
I would say it's very unique, and the
Oh,
only reason why is because typically what you don't typically see this level of ability, in particular about providing acute pain service kind of scenario,
yeah.
unless you're in an area that has residents
Mm,
that are working 24 hours a day, 7 days a week. We staff a little bit different here at CGH, in particular from an anesthesia point of view. So it does provide someone available to anesthesia to the entire hospital for 24 hours at a time. So that makes a huge difference because now you're available. The best ability is availability, right? And
right.
they're there. They're available to provide these services.
I like that one. The best ability, availability. Well, if you hang out with Xavier long enough, he has a lot of these good sayings. So that's a good one. I'll have to write that one. I have to keep that in mind. All right, good one. Good one. All right. Anything else on the OR side, anesthesia-wise, Xavier, that you'd want to add to what we've been chatting about?
The biggest one is when you're it's time for you to have surgery or procedure. It's the one of the bigger questions is a lot of people is am I going to have pain afterwards? Ask about what options are available for pain. There's plenty of options. There's actually something called opioid free anesthesia that's out there that we could use certain types of drugs to kind of alleviate opioids in particular. We can use non-steroidals, anti-inflammatories, and those kinds of things. We could use nerve blocks. You can use something called lidocaine, which is a local anesthetic kind of drip that actually provides some coverage. So ask about options in particular. I can tell you from our standpoint in anesthesia, whenever that person comes to see you, we're willing to talk to you about those things and give you the options that are available.
Yeah.
Obviously, there are some certain patient populations, some certain issues that we'd have to work out, particularly if you're on blood thinners and those kinds of things that might make a difference. However, just ask about options. We're happy to help you out with those and
Yeah.
provide them.
You see that question below, Xavier? You want to take a look?
Let's see. Could you also discuss post-op non-opioid pain management besides blocks, and for those who cannot tolerate NSAIDs? Okay. Yeah, there's, pain. Great question, Julie. There's plenty of options that are out there. Non-steroidals can cause some GI issues. It can cause some renal issues as well. We could use local anesthetic, for example, lidocaine. We could use something called NMDA antagonist, called, for example, something like ketamine. We could use magnesium, which is a simple IV medication, but it actually does blunt pain, in particular in the spinal cord area. You could use, there's also IV Motrin that's actually coming out. You can actually take something called gabapentin ahead of time. We can do multimodal techniques and avoid NSAIDs as well as nerve blocks. So there are multiple drugs. Pain is actually distributed along a huge spectrum. For example, when I teach students about opioids in particular or any type of pharmacology, I use this old reference of lock and key kind of scenario. Opioids and pain in particular only is one or two or three different keys. There's about 50 other keys that you can actually use to open up those areas to actually help out with pain. So there's all different types of medications that we can use. Obviously, they all have some have side effects, some don't, that are less prominent. However, we can work with you and figure out what's going to work best for you, especially with your health history.
Yeah. And I'm just to throw in there, just you can comment on this, Xavier. I mean, I'm hearing that with some of the blocks we're able to do for some surgeries, patients sometimes may not need pain medicine, or they might just get by with Tylenol.
Absolutely.
Not to
And
say, it's not.
pain,
Go
go
ahead.
ahead, Dr. Berg.
Well, and it's not to say that we still give out prescriptions for opioids post-discharge for patients. So it's not that we don't do that. It's just
Right.
We're trying to either not have opioids or reduce the amount that folks get. But go ahead, Xavier.
No, I was going to say, there's other ways to help mitigate pain. One is so simple. We've always done it our whole entire lives. We just didn't know the reason why. Is putting ice. Ice. That's a chemical version of almost like a radio frequency ablation.
Yeah.
You're putting cold on the nerve fibers to actually help to impede processes. Even massage, music, all of these things actually do play a role when it comes down to pain mitigation. So those are our options.
Yeah, good. Thanks, Xavier.
Absolutely.
Before I let Xavier go and go back to doing his anesthesia and managing the pain clinic work, do our viewers have any other questions they want to put to him? Because if he's leaving, you're not going to get a lot of great answers from me on this one. I'm at the end of my rope in terms of information on this.
Well, I think you can come up with some good answers, but yeah, we've got plenty of answers for you. If there's, most important, if you're coming in for a procedure, you're coming in for a consult to see Dr. Ibarra, ask for options. We're willing to give you the information so that you're educated, that you know exactly what to expect, and get the outcome that you're looking for.
Perfect. Xavier, thanks a lot. Great having you on Facebook Live. It's just thank you so much. Yeah, I agree with Julie. Yeah.
Thank you, Julie. I appreciate your time, ma'am.
Yeah. Okay. Thanks, Xavier. I'm sure.
Thank you.
All right. All right.
Have a great day, sir. Thank you so much.
Yeah. All right, bye. Okay. So I want to kind of transition into what's going on with COVID in the area, and it's going. So as I'm talking, if you have questions, please feel free to send those. I'll be glad to try my best to answer those. Yeah, okay. So first question is, someone wants to know how many beds for COVID do you currently have available? We're going to have about mid-40s in terms of beds available for COVID. About 30 on the surgical floor, and somewhere around 15, 16 in the CCU. Right now, we have 38 patients in the hospital with COVID. That sounds like a lot of patients, and it is. But what makes it sound even more impressive, and not in a good way, is that we only have, right as of this morning, and granted this all changes from hour to hour, but this morning we had 38 COVID patients, and we only had 24 or 25 non-COVID patients in the hospital. So it gives you some sense that it is the real deal in terms of what you're reading about across the Midwest. Is we're living that as well. So we are working, our staff is doing a great job, but it is a surge. And I was reading today where the surge in the Midwest now has actually lasted longer and lasting longer than the surges that happened in March and April in the Northeast. And the surge that happened in, I forget, it was like July-ish in the South. Our surge has now lasted longer than those. And if you see the numbers like I do, so far at least, doesn't appear to be any signs of a reprieve. So yeah, that's kind of where we're at. Our laboratory, in terms of testing that we've done, I didn't get today's numbers because our lab director is busy. Well, she's busy doing other stuff, but yesterday we had done 11,255 tests. We had 1,556 positives. Matt will probably put up the Whiteside stuff here too. And we had 9,405 negatives as of yesterday. Just to give you some perspective, I think it was the day before yesterday, we did 280 tests throughout the hospital between Ready Care, the ED, and those kind of places. And we had 101 positive tests from 9 o'clock yesterday morning to 9 o'clock this morning that came back. So definitely very, very active in terms of the virus in our community. Yeah, here's some Whiteside County numbers. And I'll get to that question in just a second. Thank you. Would you pop that question up one more time, Matt? Okay, so yeah, I'll go to that question. So the question is, if someone has had COVID, and is it okay for them to go to in-person school now because they have the immunity? Okay, yeah, I'm sorry, I'm getting another text here. Let me just kind of take a look at that. My sense on that would be that you have that 3-month window after someone's infected, that we think that they're not going to get it during that 3-month window. That's kind of our comfort level right now. It may be longer than that, but we're not sure. So my general response would be, yeah, it seems like going back to school, if you've already had it, would be reasonable. I always defer, though, to the health department on those kind of questions because that's the world that they definitely live in. So I would obviously defer to them, and the school nurse wherever your child goes. But in general, that would be my answer. I had another question. Keep asking questions as they come. I'm more than willing to answer them as best I can. What did you say here, Dana? Let's see here. Okay, so I want to talk a little bit about what we're working on in terms of contingency plans with COVID right now. So, there's within Ready Care, we're seeing a lot of patients. Monday, I think we saw 191 patients that went through there on Monday. And obviously, what goes without saying is we're trying our best to streamline that process, but there has been some significant delays, and we apologize for that. We're working on that, but there's also just a certain amount of volume that it's tough to work through. We're kind of thinking of how we can make that the flow of that be more patient friendly, and we're working hard on that. But we're working on it. There's a lot of things we're working on. Other things that we're working on is within the area, within the region. There are conversations about. We're working on things in case if there's more overflow issues that we have to deal with. What else did I want to talk about? Let's see here. I know, and so we're also working just on a standpoint of, if the numbers continue to go up, we definitely have plans so that if you have a health condition, something other than COVID, we're making sure that through our processes that we are going to be able to take care of you too. So I don't want people to get the impression as I'm talking that, there's not going to be space or ability for us to take care of folks who come here and need to be cared for. We are not in that position right now. We're still able to do that. we're actively we're actively working on making sure that as this surge continues to go forward, that we can address people's needs that come to the hospital. So I want to make sure folks are aware of that. I don't want to unduly alarm people because we can meet those needs. That being said, I'm saying these things because I just want folks who are listening to get a sense that our hospital, like almost every hospital in the Midwest, it's a real deal, and it's something that we're asking folks to do a good job on their end of masking, staying 6 foot apart from one another, all those kind of things to begin to reduce the number of cases that we're having in our area. Because the reality is that and I'm sure some of you who watch this are pretty active in being aware of what's going on. We are seeing encouraging information now about vaccines, and that this Pfizer vaccine, for example, the initial trials are looking like they're about 90% effective for people that get that vaccine. Well, that's going to be a nice, really helpful thing. That being said, that's probably for medical community, that's probably sometime late December through January. And for the general population, we're probably talking, from what Dr. Fauci said, sometime around April. So right now, my hope would be that we can do some things as a community to bend the curve back, bend the surge back away from where it's at right now, and keep it down until we can get more of that vaccine available and get that to folks to really drive up that herd immunity. And I truly do see light at the end of this tunnel. We just need to get through this time right now with as few people as possible getting the virus, which also puts less stress on our hospitals, including CGH. What other questions do you have? I do have one other good piece of information. I don't know if you remember hearing about that President Trump, when he was sick with COVID, received a monoclonal antibody by a company called Regeneron. It looks like the FDA has given emergency authorization, they kind of approved it for an emergency basis to start giving to patients across the country. And it sounds like a small number of doses are going to be sent out pretty soon. I don't know how many will make it to us, but I do think at some point in time in the future, it's likely that they'll ramp up their production to the point where patients can receive that. And it's an interesting medicine because it's actually an injectable medicine that's meant to be given when you test positive and are sick, but before you get hospitalized, to try to prevent people who have certain risk factors from having to go into the hospital. I know the president was hospitalized and received it there, but it sounds like for the general public, that's going to be more of a niche for you're sick, we know you're positive, let's give you this medication to try to help out. So I think that's a positive thing coming our way too. Okay. From Sydney, do you see the clinic shutting back down again? I don't at this time. The reality of what we are doing at the clinic, we're still doing a really good job of keeping folks who are, first of all, the masking in our clinics are just, you got to wear a mask, and the staff wear masks. And so it really knocks down the risk that you'd have being exposed. But we're also obviously still having people at the door that are making sure that we screen folks and try to have folks come in who are not symptomatic. So, and the other reality here is that we realize that the beat marches on for other medical conditions. So this pandemic has been going on long enough and will continue to go on at least for some period of time longer, that we just can't have our patients not have their other medical issues addressed. So I would say that right now we don't have any plans on cutting back on clinic visits. or restricting that as I sit here and speak to you right now because of those reasons. Granted, a week or two from now, things may change, but that's how we're seeing things right now. And then that last question was elective surgeries. Yeah. Elective surgeries, I would put into two categories. There are elective surgeries where you go home the same day and elective surgeries where you stay in the hospital afterwards. The elective surgeries where you go home the same day, I think we're good there. We're still good on the ones where you can stay in the hospital, but it all depends on the number of beds that are available. So right now we're doing okay with doing those surgeries where you'd have to stay in the hospital overnight. But obviously it just depends on the number of cases that we have that are hospitalized in terms of that. Across the Midwest, that's definitely an issue that hospitals are all working through, how to continue to provide service for the patients who, as I mentioned, still have medical problems that need to be addressed, while at the same time caring for the surge of COVID patients that are showing up to be taken care of as well. Good questions. What else? Oh, thanks, Marianne. I appreciate that. Our staff is doing a bang-up job with taking care of. They always do. They always do. But right now, I'm very thankful for them. Very proud of the work that they're doing and how they're just really. It's a cliche, but they're really stepping up to take care of these patients, all of our patients. Okay, Ellen, do you have resources on where to donate plasma and antibodies? The Quad Cities, the Mississippi Valley Blood Bank would be an option in terms of the plasma and donating that. I'd encourage you to give them a call. To be honest with you, I'm not sure. I don't know what they're doing, whether they're taking those at the moment or not. I think in terms of treatments for COVID, I think the plasma is not as doesn't seem like it's doing as well for patients as some other stuff. But it never hurts to call. I'd appreciate it if you give Mississippi Valley Blood Bank a call and ask them if they're still taking donations for the antibodies. Reverend Gaulick, what would you like to see from community leaders to help turn the tide? I guess I would just say, the things that just encourage all the stuff that makes sense, which is avoiding large gatherings, and masking all the time, and if you're in a big groups, keeping apart. I don't think it's. I appreciate that question, and I think for everyone, I see everybody as a leader in this, in that we all every day have an opportunity to model what makes sense and what is the best way to try to keep as many people from getting sick as possible. So yeah, and I guess the thing is if folks have a different opinion about that, I respect that, but I also think that if you have a relationship with someone, it can have a conversation about it and not an argument. I'm hoping that this conversation or my comments here today are helping you to understand that there are repercussions to following the guidelines in terms of how that affects our most vulnerable people in our community and how that plays out at a hospital. Okay, positive and you're quarantined. Okay, I have an outpatient procedure on the 24th of November. I have to be tested Saturday before. Will my test show positive? Well, I haven't get my procedure done. So I'm not sure. Good question, Sydney. So if you're positive, you're actually isolated. If you're not positive, you're quarantined, by the way. I know that wording gets thrown around a lot. At least at our hospital, my understanding of the process is if you're positive, you have to have 2 negative tests before you can have an elective surgery. So if you were, could you throw that question up again, Matt? Let me take a look at that. On the 24th of November, today is the 12th. Okay. So it depends, Sydney, when you were, when you first had symptoms and became positive. You know, those tests can stay positive. We've seen for 6 to 8 weeks. A lot of times they're not positive after 2 or 3 or 4 weeks. Everybody's different in terms of when they stop being positive. But at least at CGH, what we're looking for before we'll do an elective surgery on you is you have to have 2 consecutive negative tests, which I believe have to at least be 72 hours apart, but don't quote me on that. But I know it's 2 negative tests. So I don't know. You may or may not be negative when you have that test done on the 21st. I think it's unlikely, but I'm not. Everybody's different as far as when their test pops negative. Good question. Oh, thanks, Luann. I appreciate that. Other questions? I want to leave everyone with just the understanding that we're going to get through this. The hospital has done a fabulous, I mean, I'm part of it, but I think we're doing a really good job of managing all this. And it's a daily, you know, it's an everyday ongoing how to handle different situations. But we're going to get through this. We're going to come out on this, and it's going to be all right. But I do ask, and my other message would be, just as always, just encourage folks to do all they can to help bend the curve back in the right direction, and have that hope that, and knowledge that there is light at the end of the tunnel, with some treatments as well as some vaccines and other things that are coming forward in the next few months. Donna's asking, is it true Medicare is not giving COVID tests anymore? No, they're doing COVID testing, Donna. They're doing that for anyone who comes through who has symptoms, or essential workers who are asymptomatic. If you're asymptomatic and you're not an essential worker, then those are the folks that we're asking to go to the health department, because just in terms of the number of tests that we have to be able to do. But otherwise, we're still doing those. Thanks, Pat. I appreciate that. Appreciate that feedback. Hey, I've gone longer than I planned on, but I thank you for your questions. They're really good, and looking forward. We'll chat again next week. Until then, thank you and have a great week.